have a 21-year-old male who's just a student, no comorbidities, BMI of 37, undergoes a lap OAGB. On post-op day 1, the patient has a lot of nausea and vomiting. Early morning, post-op day 3, your resident in the hospital gives you a call and tells you, sir, the patient is running high-grade fever, but abdomen-wise, I don't think anything is wrong. What thoughts are running in your head, Dr. Palip?
A 21-year-old chap with no comorbidities, BMI of 37, OAGB, nausea, vomiting, and fever coming up on day 3. Abdomen, like I had already mentioned in the talk earlier, you may not get the same finding that you would get in a normal weight person for his height. You're probably looking at a sepsis building up inside, most likely due to leak. Probably look for tachycardia, look for the blood pressure if it's going down as against what was the preoperative blood pressure or blood pressure on induction, and you will know that there's probably a dip in the pressure, and tenderness at the surgical site, and labs pointing out towards raised count. I think the next thing would be an imaging modality to determine if there is something building up. A CT scan, you've already started. More often than not, we start our patients on orals in 6 hours after surgery. So obviously, if the patient has already taken some amount of oral and is throwing up, we can definitely try and give some contrast and try and pinpoint if there is a problem there, whether it's a stomach staple line problem, whether it's an anastomosis leak, whatever it is, we'll probably pick it up.
Okay. Dr. Praveen, this patient now gets transferred to your center. What are you going to do?
First of all, I think before even we address this case, and I think for all the surgeons who are seeing this, I think we need to first question the whole surgery itself that was done on this patient. You have a 21-year-old patient without comorbidities, 37 BMI. I think why on earth should any surgeon do an OAGB? I can keep an open bet on anybody for actually doing this. I can debate on this. Number one, such a big blunder. I would say it's a blunder. I would say, in fact, you can equate it to negligence also if this was actually an original case. Because I think MGB is a procedure that we have less than 10 years history. But I think from the history of the past, we know for sure there is something called, because of bile, stomal malignancies have been reported in the past. And that's why one of these evolution we have gone to Roux-en-Y. So that is why whenever I talk for OAGB, I always say, if you really want to do OAGB, do it on somebody that is above 50 years of age at least, because this stomal ulcers, malignancies may take 25 or 30 years or so, while the patient is already gone. But without having any long-term data, trying this on a young patient is an absolute negligence. You're putting somebody at risk. In 30 years, if this patient is going to develop, he would be in his 50s, which is not something we should be doing. Because when other procedures are working, there is no need why we should even choose this procedure. And I think completely against this particular thing. If this was a particular patient, all of you, please take home that message. You cannot just do something for the sake of doing. It is not about doing good. It's about do no harm. That is the dictum on which that we're going to follow. He loses weight, he doesn't lose weight. That's an absolutely different point. We cannot let a thing that go around, obviously speaking. So leaving that aside, I know that's not the question. I think this patient...
I'm happy that you pointed that out, because that was going to be one of my next questions, because that's one of the reasons why I have put this case up, because it needs to be highlighted that you can't just do whatever you want in anyone. Continue, please.
Okay. So yeah, so that is the first aspect. And now we know there is a leak. And leak is going to be bile leak. This is going to be even more bad. So you have to obviously intervene and do it as quick as possible. I know there are the MGB clubs, MGB surgeons have a way of doing it. I think they claim going and dividing the jejunum and doing a gastrostomy. They end up doing a gastrostomy. I don't understand why. I think my whole point is, this case close the leak, because it's only the third day. You can actually do a good omental patch and come. It will take up. Instead of doing too many things, you can just do that. But if it's too septic, if it's too bad, then maybe you divide the whole part of the jejunum. Then you can do a gastrostomy and then you can come out. Otherwise, if it's going to be too early, you can just do a regular Graham's patch and come.
Right. Dr. Bharucha, any other surgical options which run through your mind?
No, first of all, this is alarming to me for two reasons. One, as Dr. Praveen has already said, I was surprised that this person has undergone OAGB in the first place. And the second thing is, now if the CT is showing a leak, I mean, obviously, most probably it's going to be an anastomotic leak, but then I would like to first know the location of the leak. Second, if it's an anastomotic leak, then I would be very, very apprehensive of doing something, something which might not take and patient would have another leak. So I would probably, because I'm not that experienced, I would probably just take down this OAGB and convert it into an RYGB.
Right. Dr. Palep, any role of a feeding procedure, would you recommend one?
I'm always for a feeding procedure, especially if the patient is an elderly person, because they don't give you too many chances to come around again. And especially when, he's a young patient, of course, and it depends on the kind of sepsis that you have found and what kind of a situation you land yourself up in when you're doing the laparoscopy. And on table, I would more often than not err on the side of doing a feeding procedure than not doing one.
Right. So once again, it's very important to maintain the nutritional status of these kind of patients. You may think that, just because they are overweight and pre-existing, they had no other nutritional abnormalities, but post-operatively, these patients can deteriorate really, really fast, because once again, going back to our first talk, obesity is a state of chronic inflammation. It is an actual disease. And once you have a super added sepsis on it, you need to make sure that the patient is well controlled in every possible aspect.